The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Welcome once again to the Pediatric Lounge. This is your host, Dr. Herb Bravo, and with us is Dr. George Rogu, host of the Pediatric Lounge. We have the pleasure of welcoming Mr. Chip Hart from Physicians Computer Company in Burlington, Vermont. Chip is the chief evangelist for pediatric independent practices across the country and one of the most knowledgeable data scientists in the space of pediatric independent practice. He's a good friend of George and mine, and we're really glad to see him in the lounge as we record 2 episodes this week. One on general pediatric practice and a second one with a deep dive on data of pediatric practices. Please welcome Chip to the show. Morning, George. How are you?
How you doing, Herb? It's Tuesday morning once again. We usually elevate great physicians on this podcast, but we decided that we're going to bring in some great consultants too. And the one great consultant in the medical field that I know is Chip Hart from PCC.
I was going to say you couldn't get him, so you got me instead. That's good enough. Yeah, like whoever that great
Chip
consultant
has taught
is.
me. He doesn't want to take credit for it, but he's taught me everything I know. He really has.
So welcome to the podcast, Chip. There's no doubt I'm one of your biggest fans. I think you're one of the first people that started using data in medicine to actually tell physicians what to do and how to do it right, way before data was sexy. And you're a chief
data has always been sexy, but yes.
But you're a chief evangelist for the independent pediatric practice. No one else advocates as loudly and as effectively as you do. And we all thank you and admire you for that. And I think you have an honorary degree in pediatrics. Many of us see you as one of our colleagues. So it's a pleasure to have you here today.
That you've fulfilled your compliment quota for the entire podcast. So from now on, you guys can pick on me all you want.
We will. Don't worry about that.
Yeah, I know. but thank you. I'm glad to be here. You know that anyone who is advocating for independent practice, especially primary care and especially pediatrics, is someone I'm going to support. So here I am, and glad to be here.
Great. So I'm very interested, and this came up today again, on all this movement of women in pediatrics, because my whole life as a pediatrician has been peppered with lots of women pediatricians who have been my mentors. And what I hear a lot now is the opposite. I can't find a good male pediatrician to complement my staff because 50% of the kids are boys. And sometimes, just like the girls, they don't want the opposite sex doing their physical. But I hear a lot of how important it is to elevate women in pediatrics. What's your take on that?
Well, we could fill the next 45 minutes, but I won't do that. Pediatrics was, when I started in this business 30 years ago, a little bit more than that, all of my clients were old white guys. And I was good at talking to them because I could identify them. I wasn't old yet, but I understood them. And I'm talking about your former partners.
I know. RBK used to be a boys' club.
Yeah, that's exactly it. And so the entire profession, the profession of medicine is still overwhelmingly a boys' club. Like, it's not even remotely close. Okay. Even within pediatrics, the leadership positions are dominated by men. And that shouldn't be a surprise. This isn't. I'm not making a judgment there when I say that. I'll make plenty of judgments later. A lot of those positions are held by the people who gained enough experience or prestige or power in the organizations that we're in, and that comes with time. And at the time, those people were men, so we shouldn't be surprised by that. The pathway, though, to being a pediatrician, or the goals of female pediatricians, they vary widely, just like they do for guys, but there's no question socially there are different demands that are made of women than of men. That's still absolutely true. And I really actually, I'll tell you the day I had an epiphany. Because I think you'll both recognize this, because I've spoken to you both plenty of times in the past about, how to run your practice or what's going on in your office, or we argue about something. And we will discuss it vehemently, as we'll say. And the way I operated as a consultant all the time is I would visit a practice or work with a practice. I'd look at their numbers. I mean, George, how many times did you and I go through this dance? Like, you would send me some numbers. I'd look at something. I'd say, you should do this. And you'd say, well, I want to do that. And we'd talk it through, and the whole goal that I always had was that George his goal was to maximize the impact of his practice, to make the most money, to take care of the most kids as possible in the best possible way. It was to grow or to evolve. It was to become a bigger, better practice. And if I gave him a list of 10 things to do, he could delegate somewhere between 5 and 10 of them right away. He could say, okay, Chip, you're right. We have a problem with collections at the front desk. I have a front desk manager. I'm going to sit down with her. We're going to work out this plan. That's how it worked. And I remember I was working with a practice of ours. There's a solo pediatrician. She runs a cute is demeaning. I don't mean it that way, but it's this really great, tight little practice. Like you would want to bring your kids there. Okay. She runs this great little practice, and she called me up and she said, hey, can you look at my practice? Can you give me some input? And I said, sure. And I gave her a list of 10 things. And then about a few weeks later, I was in her town. So I went to visit her office, and I sat down with her, and I had my list like this. I had this list of paper. I'm like, all right, let's go through your 10 things. All right. Number 1, you haven't done this yet. Number 2, and the reaction I had in my head, it wasn't a fully conscious one. It was like, okay, she's not really very serious about her practice. And I just sort of started to turn the gas down a little bit. I'm still glad to help. I'm still glad to go over the list. But then as we're sitting there, this is in the middle of a weekday, this like 4, 5, 6-year-old girl sort of like skipped through. And she was like, oh, pardon my daughter. Like, I can't remember what it was. She had pink eye today and she couldn't go to school or something. I don't remember what it was. Something was keeping her from going to school. And it hit me like, she had no idea. I've never told her the story either, but it hit me like a ton of bricks. I was like, wait a minute. I am such a jerk. I've assumed that her goal all along was to become a bigger practice and a more impactful practice to thousands of, like, I was trying to maximize her revenue. She's trying to run a practice and take care of the kids she has and also take care of her family. Okay. Because her daughter wasn't at her husband's office. Her daughter was at her office. And what I needed to do was amend my consulting, not to give her 10 things to maximize her practice, but maybe highlight 1 or 2 things that she could do as a solo pediatrician to make her practice more sustainable, to give her a 3 or 5 year vision so that when perhaps her daughter's older and she can spend more time on certain things to get her to the point. And so really, it's not a matter of who works harder, who works smarter, who works more. It was more a matter of working differently. And that was like this moment I had, like, wow, given that, and like literally 95% of the startup practices we work with are owned by women, not 60%, which is the graduation rate. Okay. It's 95% are owned by women. I've got to think about the way I run our business differently. And I've got to think about how I approach this business differently. So I know that your time is tight. And we have other things to talk about, but there's
plenty of time.
This is deep.
So tell me, Chip, what does a younger pediatrician look like today?
Okay, so obviously, when you ask a question like that, and if I paint a picture, it's going to be inaccurate for a big chunk of people. But the incoming pediatricians are overwhelmingly female. I mean, overwhelmingly female. And there is a much, much higher percentage of people of color coming into the independent pediatric space than there was 20 years ago. I actually did. I blogged about it a couple of times, and I've spoken to the academy about it. I'll put it this way: when Suzanne Madden and I teach a class at the NCE about how to open a practice in 5 easy steps, the room is always packed, and it is packed, frankly, with brown women. And I've said this in the meeting. I said, take a look right now at the people in this room. Now, it's not universal, okay? There are plenty of people who look like me, okay? But I say, look around in this room. Who is the driving energy behind opening these practices? Who's got the vision and the desire to do her own thing right now? I said, if you look around this room, and then when this class ends and we go back out into the big NCE hubbub that we're all going to be at in 3 weeks, take a look at the demographic difference between who's in this room starting practices and who is out there in academia and everything like that. Like the difference is very visually identifiable. And so, of course, there are exceptions. The other thing I'll add, this is also natural. I say this without judgment, okay? But if you think about it for a sec, the invisible hand of capitalism, if you're going to start independent practices, okay, nationally in the United States, where are most of the pediatricians going to show up? They're going to show up where the suburbs are. All right. That's why, but neither one of you guys can throw a rock without hitting a pediatrician in your town. Okay. You guys have more pediatricians around you than just about anywhere in the world. Okay. And that's because you have that population density. And frankly, you have a lot of suburban privately insured kids. That's where the practices go. That's how you want to open a business. So if you're trying to open a business now, where are you going to go? You're going to go where where the spaces are. And a lot of that space, the majority of the United States needs pediatricians, and that space is either highly rural, right? Let's call it the state of North Dakota. Okay, all of North Dakota needs pediatricians. South Dakota, Kansas, Missouri, like the non-urban parts of those big Midwestern states, but also very, very rural, or pardon me, very, very urban areas need pediatricians. So a lot of these pediatricians are opening high Medicaid practices, and a lot of them are returning to the neighborhoods they grew up in. These are very mission-driven people. To me, it's an absolutely fascinating evolution in the business. I want to just make one quick remark. I'm clearly not opening yet, at least the little genie bottle relating to direct care, because there's this other smaller but also poignant group of people who are doing direct care practices, and that's people who don't take insurance at all.
Yes.
And you guys need to get, I don't know if you have, if I've missed it, pardon me, but should definitely get some direct care people on here, because
we just did three podcasts on that.
Yeah.
All right. Awesome. Awesome.
Yeah.
It's a very, it's very compelling.
It is.
And I know some people who do well, and they don't do well because they're only handling the rich and famous. They do well because they're painting their own life story, but it's not easy. It's not an easy leap, as you know. It's a tricky leap.
Yes. And then I think, to your point, what does the young pediatrician really want today? Because it's different from what George and I wanted when we graduated.
Mm-hmm. It is. Well, first of all, there's clearly a generational, it's not a generational, but, as we categorize the different generations, and the millennials who are coming through, who have a different view of work-life balance than, say, we do. And I really mean it when I say I think it's just different. I don't think it's better or worse. I think every generation has always said, oh, the people behind me are, that's always baloney. I know, George, I know what your partner said about you, and it was laughable. And that's just the nature of humanity.
Yeah.
I think, though, I don't think it's unreasonable for me to say to the both of you, some of the hurdles that you had to jump through in order to have your careers were inappropriate, were stupid. All right. The way a residency program runs is not sensical as a rule. Working 30 straight hours or whatever, whose idea was that? And all it really is a it's like your fraternity pledges, like you're getting through pledge month, like whoever lives is cool enough to be on the team, and that's kind of stupid. So I think there is.
I agree with you on that. But I remember after I did my training, and we had the overnights, and we had 1 million hours post call, and we did everything. We never called the attendings. Back in the day of the dinosaurs, remember, Herb?
Yeah.
When I came out to cushy Long Island, I started working at RBK Pediatrics. My training was, here's the medical record. Dr. Reichman said to me, welcome to Reichman, Brown and Kaplan, Dr. Rogu. Room number 11 is your first patient. Good luck.
Well, that's because you worked in a crazy practice. I mean, like,
but after doing it for a week, I said, man, this is so easy.
But you know what?
This is
okay,
so
I've been
easy.
starting to do residency talks now. I actually
Yes.
have one tomorrow. And one of the things I say to these residents is, all right, have you ever done the math about how a practice, whether it's a hospital or a private practice, wants to hire you? They have no idea, of course. And I said, well, okay, so let's go through it. And I go visits per day, dollars per visit. It's the math we've all done 100 times. So I said, so how many patients a day do you all see right now? And they're like 8, 10.
Yeah.
And I said, guess what the real world looks like? And when you tell them 20, okay, which is even
not a lot.
Yeah, even not a lot. They freak out. And so what I'm seeing a lot of is the residencies are deliberately putting out employees. They want to put out employed physicians, people who are too scared to stand on their own. I mean, I was giving a residency talk, and my talk was, it's a standard talk I have, the 60-minute course I wish every resident could take. It's just a business course. All right. It's 60 minutes of business. And I literally, I've done it plenty of times. It's never been anything but great. I mean, not because of me, just the topic. The people are like, no one's ever told us this. I had one of the residency directors say, hey, yeah. Could you cut out the slides about starting your own practice? Because you can't do that. And I was like, do you want a list of the practices I've helped start in the last 3 years? Or, we've at PCC has helped start. I mean, like, what are you talking about? You can't do it. Well, we don't want to, we don't want to fill their head with silly notions. And I'm like, you are the devil.
Yes.
That's right.
You are the devil.
I have medical students where, because it's a little bit difficult to find physicians, I figured if I have 10 medical students, just me, and the other 5 doctors have 10 medical students a year, out of these 50 students, one has to be a local kid that's going to go into peds and wants to come home in 5 years.
That's all you want. One every couple of years.
What they say is, at the end of the month, they say, thank you very much for teaching me. They learn to work the EHRs. They do everything. And they said, I never thought private practice could be like this.
You have control.
Yes.
You get to walk in and say, you know what? I don't want to do it that way. Or I just read this paper or whatever. I just read the latest position paper by the academy about something. And okay, I'm going to change tomorrow. I'm going to change vaccine products tomorrow. I'm going to change our workflow tomorrow. I'm going to do a flu clinic tomorrow. You can't do that when you work for someone else.
Yeah.
So I'm going to rephrase what you said about residency. I think the way George and I train in residency, I don't know how it is today, but it was like a Navy SEAL training.
Yep.
Lay down in the water, at night and see if you don't go crazy, because you have to be strong when the patient's in front of you.
Correct.
And it stripped you of empathy, which is unfortunate, because you're so focused on surviving.
Yeah, you're focused on yourself and not the person in front of you.
And that I think was a real disservice to society.
Well, that's in residency, but when you go into practice, it comes back. I think I'm the most empathetic person out there. I'm very nice to people. I smile all the time.
Yeah,
I want to cut that out, but I can save that for a video. But no, keep in mind, guys, you're 2 pediatricians.
Great.
You are on the empathy scale. You're all the way out to the right.
Correct.
Or the left. Pick your side.
Correct.
I mean, like you do have peers in other specialties.
Yes, you are correct on that.
Who had their empathy stamped out of them. And I will say, let me add this one thing though. This is something that a lot of people aren't talking about. So PCC right now, we have, I don't have the count officially, but any given time over the last couple of years, we've had 20 to 25 practices in our circling the airport, trying to land, okay, to come on board with us. That just startups.
It's great.
All right, it's that many. We're busy, but
I love to hear those stories.
Of those 25, at least 5 to 10 of them probably shouldn't be in private practice. That's one thing that I don't want to cover it up, but there are a lot of pediatricians, or there's some portion of pediatricians who come into the space, who want to be the captains of their own ships, who come to us and tell us these stories. I mean, I've literally heard this story many times. I grew up in this county. I was lucky to, get out of my local high school. I somehow got a scholarship to some small community college, but I ended up in med school, and here I'm in med school, and I'm a straight A student. I'm the person who escaped, and I want to come back, and I want to take care of the families in my community. I have this vision for everything. And what they don't have, though, is a vision for running a business. And that is tricky, because not everyone needs to know how to run a business, but they come into the space and they expect a lot of things to either be done for them by other people, in a weird, sort of a mildly entitled way, or that they when confronted by the reality of the things that they don't know how to do. And that you guys know this, doctors suffer from always being the smartest person in the class. So
Right.
they rarely are wrong. Okay. But the fact is, the skills that get you through med school are not the skills that teach you how to hire properly or understand how to read an EOB or whatever. And so, if you read any of the private Facebook doctor groups or you see these doctors who go on and say, I'm on my 4th office manager, and all these people are crazy. And I'm like, if you're on your 4th office manager, your office managers aren't the problem,
Yeah.
And so, I'm actually, as we speak, doing a little work with a couple of the usual suspects in our industry to try to figure out a way to create I don't know how to do. This isn't going to happen this way, but wouldn't it be really cool if I had some sort of aptitude test, like an MChat for should I own a pediatric practice? And if you scored 27 or higher, yes. If you scored 10 or below, stay working at your hospital, so one thing that is different is that there's definitely a much higher percentage of newer practices today who are going into private practice, who are not fully prepared to do so. Or an alternative viewpoint is it is probably a lot harder to open a new practice today than it was 40 or 50 years ago, 30, 40 years ago, for a lot of reasons. And so maybe it's just more obvious to me.
I think it's just obvious to you. I think it was just as difficult before. Today, the resources are there. I mean, most of the physicians, they went through medical school. They learned biochemistry and all that, physiology,
Yep.
pathology, medicine. You don't think you can learn some business? There's
I'll tell you what's
classes.
You can't. It's like
It's a
anything else.
learnable trait. It's called
No, it's
resolving
not.
problems.
No, it's not. It's about passion. I mean, Chip and I are passionate about old Mercedes. We'll deal with a car breaking down because we love old Mercedes. If you don't love the old Mercedes, you're not passionate about it. You take it to the junkyard, you throw it out, and you get a Toyota. That's always going to start. And some people are not passionate about business. In today's world, if you're not passionate about business and technology, you cannot run a business. It doesn't matter what business.
For any kind of business, Herb, not just medicine.
Yeah.
But some doctors are not passionate about business, and they're not passionate about technology. And
I think they can get away with it if they're partnered with someone who is. And when you're solo, as most of these startups are, I agree, you have to be passionate about all of the above. And then George, this is where I'll argue with you a little bit. I think it was easier to start a practice 30 years ago for a couple big reasons. I think the insurance companies are so much worse than they were 30 years ago. I think they are, and I have to use the word like in order to avoid being sued. They are like organized crime. I mean, they were then, but before, I mean, you and I could talk about, you and I agree on this forever, but some of the shenanigans with narrow networks, with credentialing, with, I mean, like when you first started, you used 20 CPT codes. All right. and there were 5 vaccines. And now it's a lot more sophisticated. I think it's academic, and you can absolutely, if you got through med school, you have the aptitude. But I think Herb's right that you have to have that passion and that drive for, especially the smaller you are, for all the elements of running the practice, and not everyone does.
But I think a person has to be able to resolve problems. Most doctors are good at resolving problems. They have to want to resolve them. How did I meet you, Chip? I interviewed with Rush and Brown and Kaplan. They would totally paper everything, even paper claims
Yeah.
and billing. They used to move
Yeah.
floppy disks around. They said, "You're the young guy. We need to get a practice management. Go find one and tell us what to do."
Mhm.
What was that going to say? I had no idea. I had no experience. I went on the internet, which the internet, remember back in the days of Lycos and those guys? I
Yeah,
typed in pediatric practice management software. What happened? PCC popped up.
I'm surprised it worked.
Well,
Like
back
that's
then, you know,
yeah,
but
back
I
then.
filled out a form. A week later, this nice brochure comes in that looked pretty good, but I didn't know what accounts receivable or any of that jazz meant. Do you want a demo? That was back in the day when there was a baby Chip. Remember when you guys used to have those big monster luggage boxes when you ship out a laptop?
Yeah, I'd ship you a laptop. I was skinny back then too.
Yeah. You
So-
showed
You
me
know.
some stuff that I didn't know what it was.
So George, I again, I'll push back a little bit. I think that you have a really great ability of execution,
Yes,
and you like to learn new things.
correct.
Yes. And you're not afraid.
No,
There's a lot of physicians that are maybe a little bit older than me or my age, or even younger, that every time you give them a solution, they push back. Either
Right.
I'm
Oh,
doing
yeah.
great, I'm doing great,
Yeah.
and I'm like, no, you're not doing great, or you can do that. Oh, but I'm not. Oh, but really, I can automate the texting to call back my patients. I don't have to have someone call them each individually.
Yeah.
No. Or, when I say this and people think I'm just being a jerk, don't schedule your Medicaid patients far in advance because they don't show up. Oh, that you're being mean. No, I'm not being mean. That's the data that Chip has. The Medicaid patient that missed an appointment is much more likely to miss the appointment than somebody that's on a Medicaid. So
Right.
you have to have a different strategy for that patient to come in for their well child vaccine and for their flu vaccine. It's not a one way for everybody.
Wait a
But
minute.
you have to want to learn, and you have to keep educating yourself. You want to
Yeah.
talk to people, like Chip always says. You want to visit other people's practices to see how they're doing it. And not everybody has that type of personality.
Yeah, but you know what
Yeah,
this is all called? This is called practice transformation.
It's
That's
you have
all
to
it
not
is.
be afraid of change. And
Yeah.
and the idea that what the two things that frustrate me are when people are afraid, and more so when people simply have either given up or feel like they know it all.
Yes.
The moment you know it all, you're done. Oh,
Yep.
you can't do anything about that. You can't.
Right.
Oh, you can't do anything about that. I mean, the most classic example of that, and it's just there are bigger and better ones in some ways, but this is one that everyone understands. Is I look at HPV rates, HPV vaccination rates all the time, because to me it's a pretty good measure of a practice for a lot of reasons. And and as George knows, we give out awards for these things. he misses his dashboard awards. I know he does.
I
So
know.
yeah, when I meet a practice and and I'm like, well, you've got a 28% HPV vaccination rate. I always get this, well, we can't do anything about it. Our patients are this, or we live in the Bible Belt, or our patients are really hesitant, and you're like, you don't understand what it's like to work in this town. You don't, and I'm like, I have another client in your town who has like a 93% vaccination rate, and she's 75% Medicaid. So I don't want to hear your reasons why it can't be done. That old saying, like, I'm going to screw it up right now, but the people who are saying it can't be done, versus the people who are out there doing it, whatever the saying is. I've already forgotten.
So back to that
yeah,
point, Chip. I
please.
think I really like this personality inventory. It's called the Big Five, and
Oh, yeah.
I'll send
Yeah.
you a link. I think that when you're taking on a client, I want them to fill that survey first, because if they are really, really low on being agreeable and very neurotic, I don't have time for them.
Yes.
And
it has to be an objective test, because everyone thinks they're agreeable.
and no, but it just teases that out, and
Yeah.
that's true of employees too. I mean, if I'm going to spend half my day arguing with someone about how to do something,
Mhm.
I just want to go to the beach and drink beer.
Yeah,
You know,
well, I want to
that,
do that anyway, but yes. Yeah, no,
well,
no,
so
I'm a
that's
big
one.
fan of those.
And then, you know, and I think we had someone that we, you know, he's always in trouble. And I asked him to take the test and he said, oh, I'm not going online. I don't want them to steal my data. And I said, what's your percent of patients that completed both HPVs by 13 years of age? At least 98%. I
Yeah,
said,
bullshit.
how
Oops, am I
did
allowed to swear?
how do you know that? Oh, I just know because I have a really, I run a really tight
No,
practice.
no. No one knows that. No one knows more than I do. The lie
Oh,
that,
no,
that
but
that's
see,
self-deception.
so,
Yeah, no, like
so that's when I like this guy should not be running a practice. You know,
you're
this guy should
exactly
not be
correct.
running a practice. I will not buy his practice. I don't want to be coaching him how to get out of this because I'm going to pull out all my hair and not make any money at it.
Yep.
There's one time in my career that I was burned by a doctor when I said, oh, you know, I used to do, you know, because I was in sales and I would go to an office and I knew the benchmarks and I knew how practices worked. I could ask a couple of questions. I'd look and I'm like, okay, they don't have a recall program. And I kind of looking at the age of the kids coming in, they're just a couple guesses you can make. And I'm going to be like, okay, there are 5 of you. And back then there were 2,000 patients each. All right. So it's about 10,000 patients and about 20% of them are teenagers. So that's 2,000 of them and 50% of them haven't come in. I'm like, you're going to have at least 1,000 kids over the age of 12 who are overdue for well visits. And a well visit back then would pay like $200. So like there's $200,000 or what, you know, I would just do this math in my head and they'd be like, no. And I'd say, let's pull a sample. Let's pull 5 charts and see how many. Always right. Every time I was right. The only time I ever got burned, ever, Jill Stoller killed me. She was like, no, we have a recall program. I'm like, yeah, let's see it. She came out. Yeah. Okay. Jill Stoller had a 95% well visit coverage rate before she had our system. I will always remember that day because she was like, oh, you know, I thought I had her busted because she said exactly the way you did her, which is, oh no, I just know. And when I hear that from a doctor, you know what I call that? Actually, it's obvious, but the expression I have for it now is called evidence-based practice management.
Yeah.
If you're running your practice based on your feel, you might as well not take labs, temps, or weights or heights either. Oh, that kid looks tall enough.
That's right.
Same thing.
That's right. So let's talk a little bit about KPIs. I don't know what you're seeing with your clients, but in the commercial world, what do you think? Are we 60, 70% or 80% fee for service and then 20%?
Oh, good question.
Wrap around.
Yeah. First of all, that's incredibly regional. So any answer I give you, depending on where someone's listening, they're going to be like, no, totally wrong, because it's going to be wrong for most people. I mean, places there in the Northeast, like in Massachusetts or in Southern California, some of Pennsylvania, stuff like that. Those places have had performance-based contracts for 25 years, 30 years. I remember one of our clients in Mass, I think it was Harvard Pilgrim or Tufts. It was one of the insurance companies named after the schools. They had like 20-30% of their revenue for years was based on their year-end bonus based on their performance. I'm talking like back in the 90s, early 2000s. And so some of that stuff has always been there. It's creeping in, but there has not been, I don't have a client who suddenly has gone from a massive fee for service contract to this whole new reward-based thing for all the obvious reasons. They're hard to implement. They know that if they do it too quickly, the doctors are going to panic, and with good reason. And it really hasn't bled all the way down to us because no one has good pediatric measures. The pediatric measures are the last thing anyone worries about, and they don't understand them. And so, I mean, for years, I'm talking again, 20 years, Tennessee Medicaids, Kentucky, some of the CINs do this stuff. Some of the IPAs do this stuff. And it's bleeding in, but I've yet to, I would be delighted if one of your listeners were to correct me, but I am not aware of a truly successful value-based payment system yet. certainly in the pediatric space.
Well,
And I don't think
Go ahead.
I don't think there will be.
You know what's happening in that world is the hospitals and the IPAs, they're the boys that connect with the insurance companies that know people.
Mhm.
And
Yep.
what they'll do is the busy physician, they'll say, okay, Herb, join our IPA or a hospital network, and
Mhm.
we'll get you some wraparound contracts. They take the pediatricians into the realm because the pediatricians usually have good quality metrics. They'll put in a couple of quality metrics that the pediatricians can succeed on. And at the end of the year, they dilute what the internal medicine messes up. So everybody succeeds. And then they throw a couple of bucks to the PD guy, and he's supposed to say, hey, thank you.
Right.
But
Which they do, because pediatricians are like, oh, look,
yeah,
we
thank
get
you very
yeah,
much.
they're like,
Yeah.
yeah.
It's
silly.
but what also happens is the insurance carriers, I don't want to defend them, but they don't want to deal with 10 little practices of 100 patients, 500 patients. So I think the best way to do it is you just collect a bunch of doctors in solo practices, 100, 500, 600, 1,000, 2,000, pull them in, make some quality metrics that are pediatric specific. Then you can go to a carrier and say, hey, I got all these guys that are all doing good quality medicine, and here's how it goes with the data. Watch how they talk to you. It's a different discussion.
Yeah, it's a numbers game though, right?
Yeah.
If you only have 100 pediatricians,
yeah,
when Optum has 65,000 physicians and they just got approved with Change Healthcare to manage all the clearinghouse, you don't have enough data points to go up and talk to them.
Yeah, by the way, I know both of you guys are against the single payer model, but did you think it would be Optum as the single payer? Because that's what we're getting.
Well,
that's who it's going to be.
Well,
anyway, keep going.
So 50% already of pediatrics is Medicaid. So we are halfway to a single payer model.
Well, yeah, but those are 50 individual payers, because there's quite a spread of style. Here's the problem that I have with the value-based care for peds. It's twofold. Now, the first thing is, number one, the return on pediatric care is measured in
quarters,
spans of decades. Yeah. No, that is how it's measured. But for the care itself, you guys know as pediatricians, the impact you're making on a newborn today could be seen at 10, could be seen at 20, could be seen at 50. Your payoff is way downstream, and none of the fact that there's money in this business means that they are not going to be looking that far down, because not a single one of the people making the decisions about who's getting paid when is thinking about their careers that way. Even they're going from quarter to corner, shareholder meeting to shareholder meeting. And so, number one, there is such a massive misalignment with the timing of the investment that's the first problem. The second problem is this, and this is the one that it's like the emperor has no clothes. So one of the biggest experiments in this model is the whole ACO model. All right. And I'm one of those people who, when I look at some of these, when I look at these really fancy called financial schemes, whether it's crypto or NTFs or whatever they're called, or any of those things, I always like, you should be able to boil it down to something pretty clear, right? If it's complicated, someone's screwing you over. And with ACOs, the model's really simple. The feds come along and say, hey, if you guys, through better quality of care, reduce the amount of spend that we have, we'll give some of it back to you, because we realize keeping people out of the hospital actually costs the hospital money, and you don't have a motivation to do that. So we're going to give some of it back to you. So that's the whole model. If you reduce the spend, we're going to give it back. We're going to give you some of the money back. I challenge anyone to tell me that it's really fundamentally anything else. Here's the problem. Pediatrics, unlike most of medicine, actually wants to increase the spend. 40% of the kids in the United States don't have a well visit in the last year. Okay. That means 40% of kids haven't had a depression screen, haven't had a vision screen, haven't had a hearing screen, haven't had eyes on them for abuse and neglect, haven't had any anticipatory guidance. We actually need a model that spends more money in pediatrics, not saves money, because later on you're going to save the money. And the corollary to that is pediatricians are diametrically opposed to the rest of the healthcare industry, because you're the only specialty that tries to prevent cancer. You're the only one. Okay. Everyone else, if we snapped our fingers like Thanos, if we snapped our fingers and got rid of cancer, all the hospitals in the United States would be on a 6-month timer. All right.
That and obesity.
Yep. Yeah, like that and obesity. All right.
Yeah.
And I just picked on cancer because right now there are something like 50 cancer mRNA vaccines in trial.
Right.
In our lifetimes, I'm hoping this is true, but in our lifetimes, my hope is that pediatricians will be giving a 10-in-1 vaccine at each of your first 3 birthdays that prevent and eliminate your prostate cancer at age 50 or 70, and your lymphoma, and like all of this stuff is actually, it's possible. Will it happen? Who knows? But we're in sight of it, and that makes you the enemy of every hospital in this country.
True.
Because they depend on cancer to stay open.
Yes.
And so that's why I think, at the end of the day, these value-based care models that's not a suit that fits. And I feel a little reactionary when I say that. Maybe I'm just fighting it, but no one has come in and said, hey, you know what we really want? We are going to pay pediatricians based purely on their well visit coverage rate. And if you can get every kid in for a well visit, then that's your goal, because that to me should be the goal of every pediatrician. That's the thing that you can do that no one else can do. That's the thing that has the biggest payoff. But they're not usually. They're punitive.
Pause here, and the next episode will air on Thursday. See you then. Thank you for joining us. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.